Hello and welcome. Let's talk about gangrene along with gas gangrene for surgery. So, what does it mean by gangrene? Macroscopic death of tissue with superadded putrefaction is called gangrene. Classification of gangrene. According to cause, secondary to arterial obstruction from diseases like Raynaud's disease, embolism, senile atherosclerosis, thrombosis including thromboangiitis, obliterans or Buerger's disease, ergotism, diabetic arteritis with neuropathy. Infective, which includes boils and carbuncles, gas gangrene, gangrene of the stomach. Traumatic includes direct and indirect. Physical, burns, scalds, chemicals, frostbite, electricity and irradiation. And venous gangrene. Clinical classification includes dry gangrene and moist or wet gangrene. So, common sites of gangrene: distal part of the limb, vermiform appendix, loop of small intestine, gallbladder, pancreas and testes. Treatment of gangrene: the excision of gangrenous part, amputation of rapidly spreading gangrene, badly crossed limb and gas gangrene. Tetanus prophylaxis, control of diabetes mellitus, control of infection and maintenance of nutrition. Gas gangrene. So, gas gangrene may be defined as anaerobic infection of muscle characterized by profound toxemia, extensive local edema, massive necrosis of tissue and varying degrees of gas production. Earlier it was called as malignant edema. The causative organisms of gas gangrene: Clostridium perfringens, Clostridium edematans, Clostridium septicum, Clostridium histolyticum and Clostridium fallax. Pathogenesis of gas gangrene: spores of Clostridium are introduced into the injury, and anaerobic conditions causes multiplication, and they use oxygen and produce anaerobic environment. Germination of anaerobic organisms, and they start to multiply and liberate toxins and enzymes which has lethal necrotizing and hemolytic properties. They destroy muscle fiber and produce gas and serosanguinous fluid. The wound rapidly expands in size, and the toxins and organisms enter into blood, and there is severe toxemia leading to circulatory failure and final death. The predisposing factors are reduced blood supply, immunocompromised condition, diabetes mellitus and malignancy. The clinical types of gas gangrene include fulminant type, massive type, group type, single muscle type and subcutaneous type. The clinical features: the general features includes features of toxemia, fever and tachycardia along with pallor. There is nausea and vomiting, jaundice. There is oliguria, which signifies renal failure. Local includes pain, swelling, edema of the affected part. Wound is under tension with thin brown, sweaty smelling discharge, khaki brown colored skin due to associated hemolysis, presence of the crepitus. This is the main diagnostic feature in case of gas gangrene. Subcutaneous tissue alone can be infected. Investigation: plain X-ray of affected part can be done. Blood for TCDC, ESR and hemoglobin percentage. Wound fluid microscopy for gram-positive bacilli. Liver function test, blood urea and serum creatinine can be done. Treatment of this established case is the patient is immediately prepared for operation by giving intravenous fluid, fresh blood transfusion, large and frequent doses of penicillin, anti-gas gangrene serum. If available, hyperbaric oxygen can be given. Aggressive debridement of the affected tissue is required, and maintenance of hydration and check in urine output, electrolyte management. In case of severe amputation, has to be done as a life-saving procedure. Now, prevention: wound debridement, devitalized wounds should not be sutured, adequate cleaning of the wounds with hydrogen peroxide and normal saline, and penicillin should be given as prophylactic antibiotic. Now, the differences between dry and moist gangrene. Dry gangrene: the cause is due to arterial occlusion, and in moist gangrene, the cause is both arterial and venous occlusion. In dry gangrene, the affected part is dry, discolored and wrinkled. In moist gangrene, the affected part is moist, swollen and discolored. In dry gangrene, the necrosis is mainly coagulative, and in moist gangrene, the necrosis is mainly liquefactive. The infection is usually absent with no any foul smelling in case of dry gangrene, but in moist, the infection is always present with foul smelling. Dry gangrene is separated by a line of sharp demarcation, while moist gangrene shows no any line of demarcation and it extends into healthy tissue. The bleeps or crepitations are absent in dry gangrene, but in case of moist gangrene, it may be present because of the gas forming organism. Dry gangrene spreads slowly, while moist gangrene spreads rapidly, so it is fatal. End of the topic.